So my topic was complications in CTO PCI, trying to set up to succeed and succeeding long-term despite short-term failure. I'm obviously not going to teach everything about complication management in CTO PCI in 12 minutes flat, but thankfully we have a room full of experienced operators. Instead, my hope is to talk a little bit about how to think about these things and maybe describe a systematic way of dealing with those who are affected by these difficult experiences, or the rich emotional experiences as we call them. These are my disclosures. So you've had a complication. What does it mean to feel bad? Think about your own complications in your past career. Do you feel sad, angry, guilty, ashamed of yourself for having caused a problem? What does it mean to feel bad? What does it mean to get better? Is that a procedural concept, or is that you as an individual, or as an operator, or as a doctor, or as a father or husband, or wife or mother? How do we go from being bad to better? So we have to start to try to understand that problem by figuring out who actually suffers from a complication. Well, we know obviously that there's the patient. But what about us? Do we have any effects upon us from these complications? Let's look at this representative case. It's an 81-year-old, EF 25%, very symptomatic, lives 7 hours from the nearest cath lab. So this was his one shot. We've been following him along for a year. And you can see that he's got fairly bad disease proximally in the circ, in the LAD, and then he's got an RCA CTO. We fixed his left system. We fixed his left system. He was a turn down, so we had to use relatively little contrast. And we came away with a reasonable final result, and then decided to go after the right. And so then we started going after the RCA CTO, which you can see here, lots of bridging collateral, so a recipe for trouble if you're not careful. We had stented across the sepals in the LAD because we felt that was the primary target. And then we got a knuckle going. And so we were very happy with this knuckle, but unfortunately, when we moved forward with that knuckle, you'll see where it went. So this was the V-gram to show that there's an infrabasal aneurysm, but this whole segment of the inferior wall is viable, which is why it made sense. So there's our final results in the left system. Not bad, right? Reasonable LAD, reasonable left main, good circ. And then we went after the RCA as described, and here's that knuckle I was talking about. So, you know what? It goes down the length of the vessel. I was actually really encouraged when I saw this. But unfortunately, or fortunately, we recognize we don't advance gear along wires until we know where those wires are. We see that this wire is clearly not in the main vessel. So the procedure was fairly long by this time. The patient was starting to get that bimodal vasodilatory shock, and we said it's time to stop. And we can stage this, there's time. So I delivered him to the CCU, and he looked stable. As you can see, the RCA here at the end of it had reasonably good control. There was no obvious leak within the mid-RCA system. But about an hour after he got to the CCU, he got hypotensive. And then the impella started to get suction events, which is always a very bad sign because it means there's either failure of the RV, or there isn't enough volume in the system, or there's tamponade. And so after about 2 hours arrival in CCU, when we kept on trying to resuscitate this with fluid, thinking in our head that this was probably all vasodilation post-long procedure, we realized that there was a rapidly expanding effusion, drained it, and ran back to the cath lab. And this is what we found. So there's our problem. So this was a rent in the inferior basal wall. This is a wire not across major perforation in the vessel as well as in the myocardium. So now we're in deep trouble. So how do we use this experience, this horrible experience where this patient who is already elderly and already high risk is dying in front of you to get better? Well, the reality of what we do is we have systematic analysis for a lot of the things that we undertake. We do these things on a hospital and on a divisional level to try to make sure that we review challenging cases like these so we can all learn from them, right? S-bars, root cause analyses, morbidity and mortality rounds. And so we can then try to approach complications with a similar sort of systematic analysis paradigm. So what's the systematic analysis paradigm that is nicely recognized and published for coronary CTO complications? Well, there isn't one, but what I started thinking about after this in these types of cases was, you walk through the forest or you walk through a garden, you smell the flowers. Sometimes you stop and think and realize something. This is the petals analysis. P is for the predictability of a complication in the context of a case. E is the event prior to the event that caused the complication. So not why did I knuckle, but why did I choose to go after the RCA? Why did I deviate from my surgical plan? What was the treatment deployed and what was the outcome achieved? This is the big data, right? This is what tells us a little bit about how the literature works and how well we are able to apply it. What's the advice for the next case? How am I going to do this next time, technically, to avoid this problem from happening? What does this teach me about me as an operator? That's the life lesson learned. How am I going to change myself and my practice to limit this type of a thing from happening again? And then sharing in support of peer review. This is the other piece of systematic analysis, making sure that our colleagues are aware and we are aware as a supportive team about complications that occur so that we create a culture in which we support one another. Now, PEDALS, this analysis does not equal the acute management. The acute management is very different, where in this case, it was more act first, think second, right? So this was the acute management. We got a bunch of fat out of his leg. I put a wire into anything I could find. I plugged it with fat. I did a bunch of balloon tamponade, shut down the RCA, goodbye perforation. Okay, we were pretty happy with this final result. Hemodynamic stability was maintained. We managed to get a drain in. As you can see, we're okay. So what was my PEDALS analysis here? Well, this was marginally predictable due to the infrabasal aneurysm. The recognition was that that's dead heart, and it's not going to seal or heal like living heart. And that's one of those finer points that often we might not consider if we're going after a fully viable mid to distal inferior wall, but recognize that the proximal RCA is probably where the vessel had infarcted a while ago, and that segment of heart is dead. So that's vulnerable heart. What was the event before the event? I hedged my bets on my procedural plan. I always go into these complex cases with a plan A, plan B, and plan C, as I'm sure many of you do. And so I thought to myself, we'll see how this goes. This may not be the right approach in very complex cases where down to when you put in what stent matters. The treatment that we employed, well, that worked, right? We used the fat injection in the balloon tamponade. It was effective. It was quick. It was the first step on the wire not across perforation algorithm. And we recognized it a bit late, but we did recognize it. So what about my next case? So this is that piece about recognizing that dead heart isn't the same. And so next case, I recognize that if I see an aneurysmal segment on any wall, that's vulnerable territory. And I need to stay away from it except for in the most safe techniques possible, i.e. you bring the patient back staged when the EF is recovered a bit and do a nice retrograde that's planned, goes up subintimally, and then you poke antegrade using the retrograde wire as a marker, as we just heard. What was my life lesson? How am I going to be a better operator going forward? Well, I stick to my procedure plan now. I don't hedge my bets. I have a plan, I go for what I'm going for, and then I get out. And I make it clear that I don't get greedy. And the presence of MCS, we're a managed system, a managed healthcare system where money matters, that doesn't change this procedural plan. And then, of course, the case was reviewed in detail with a partner. That was tough because he said, don't do the CTO. I had to hear some things, but ultimately, it strengthened our culture. But how do we feel through this? So we got through how to make ourselves better operators, but I felt awful after this complication. I felt terrible because I knew this patient and his family well. So the second victim in complications is us. And the impact is not small because when you look at surgeons who go through complications, 60% of them feel guilt, 91% depressive emotions, 67%, 68% have anxiety after a particular procedure about going back. 42% of surgeons feel ashamed despite having tried to help someone. So this is kind of sad. And then when you look at how people cope, there's a large component that turn to things like alcohol abuse, drug abuse, and these kinds of very maladaptive things to get around these. So how do you as an individual manage you? Well, we don't have any systematic models for that. So here is another approach that we developed. I actually developed this with my sister who's a lawyer, so it was helpful in trying to get her perspective on how to protect ourselves from ourselves, but also a therapist, and thought about how to get actually through the complex emotions that we go through in these difficult circumstances. One is recognize the discomfort you're feeling. Take stock of it. Understand that it's normal. 2, review it. Is there anything dangerous? Are you looking towards getting into alcohol? Because that's obviously going to affect your ability to do good cases going forward. What are the results of your coping mechanism? 3, respond with self-compassion. You didn't try to hurt this patient. You spent 6 hours, laid your gut on the floor, and tried very hard to get a good result, but it didn't work out. And you know what? The only way to avoid complications is to not do cases. Now go to redo. So if I could do this again, how would I do this differently? What's the difference in my approach today about me and how I'm going to then be shielded from this type of experience again? Do I just need a bigger denominator? Do I need to do more cases before I take this on again? So that I know in context that this is actually an understandable scenario. And for what it's worth, reframe and reach out. I reached out to a dear friend who's actually one of the faculty here, who lives in the US, we train near one another. And I said, look, would you have gone after the RCA? And he said, absolutely. You had a stable patient with a reasonable approach. And granted, it didn't work out, but that doesn't mean that you didn't do what you thought was right for the patient. So my 5R analysis was I felt awful, right? I couldn't believe this happened, but I recognized that it was relatively unpredictable, at least at that time. Now I understand that aneurysm means dead, means vulnerable heart. I felt like a fool. I felt overconfident and embarrassed, but I was thankful that we managed to figure out the problem and solve it. I recognized that the only way to avoid complications is to not do cases. I obviously felt bad because I'm a decent human being and I don't want to hurt people. And so, like all of you, we care about our patients. And I recognize that everyone is invested in a case. So the team works to keep concentration together, and we do a debrief afterwards to make sure that we actually have a pathway for us so that our team members, next time they have a CTO come into the room, don't say, I don't want to do this. And then we reframed and refocused on the patient, who ultimately, thankfully, did well. And the key is, both for the patient and for us, the ground concepts are the same, which is how are we going to change as people and how do we share our experience? And so to close out, I'll leave you with the Dunning-Kruger effect. And this is really how we work through our careers. This is Mount Stupid. And the meaning of the word stupid is not you're a stupid person, it's that it is the casualty of knowledge in a complex environment, having to do a lot of different things. As you start to do more volume, you recognize that bad things can happen, and so you move into this value of despair, which I prefer to call more the value of humility, where you recognize that though bad things can happen, we take calculated risks to try to make our patients better, but taking uncalculated risks is unacceptable. And then you move towards the slope of enlightenment, which tells us a little bit more about ourselves and says that once we have the volume, we know what we should take on and what we shouldn't. And so complications are inevitable and high risk in CTO PCI. Data can guide us about how to fix a problem, but doesn't actually make us get better or help us take care of ourselves. And so we can continue to use systematic approaches to analyze these things. One is the petals approach, and another might be the 5R approach to keep our success long-term viable.
Thank you, Sanjog. Wonderful presentation. You married science to philosophy, and that was very nicely done. We are running out of time, so I believe if there are no comments from my co-chairs, we will close the session. Thank you very much.